actually at this point. I will not be specifically going into each varieties of vasculitis which takes more than half a day to 1 day. So instead of that, what I thought is, I precisely put across what point and when and why we always should think of this disease, vasculitis. So the vasculitis, as we are aware, by definition is nothing but the inflammation of the vessel, and it could be a small vessel or a medium-sized vessel or a large-sized vessel inflammation. Based on the size, we either call it as medium-sized, small size, or a large-sized vessel vasculitis. We call it by definition as primary if there is no other associated condition, either a rheumatoid, scleroderma, SLE, or anything else, or infection, or drug abuse, anything of that which could precipitate a vasculitis. Then we call it as a secondary, otherwise we call it as a primary vasculitis. See, the major issue that comes to all of us is, why should we consider or suspect a vasculitis? See, the reason why I am trying to say is that vasculitis, as we are all aware, could be a benign, simple disease where it could be a ugly looking red scars and patches which may not really harm the patient other than looking ugly or maybe a little irritating with some irritations and itching, or may have a painful non-healing ulcers, to a devastating organ-threatening disease. It can cause infarcts in the brain, it can produce a permanent renal damage, it can cause a blindness, it can cause polyneuropathy which could be permanent, or it can lead to a devastating disability, to a death if it is not recognized properly. So this makes vasculitis to be diagnosed. In a sense, we need to think of this particular diagnosis as and when the patient walks in for certain of the symptoms, because you may be even if you miss, sometime you're okay, but sometime if you miss, you're really going to cause a lot problem to the patients. But the most critical point is, why do we don't diagnose vasculitis? Why do we still think that we miss a vasculitis? It's basically for a reason. It is really well acceptable that it is a rare disease. It's a rare disease, but it's not a very rare disease. We can still call it as a less common disease, but not a rare disease. You do find vasculitis if you look for it. Probably incidence increases more you start looking for a vasculitis. The most critical problem in making diagnosis is this: the manifestation is never uniform. It could be rash with a disease, or it could be disease without a rash. You may have a rash, you may have an ulcer, you may have an external manifestation, you may not have any. And the possible permutation and combinations are many. That makes us always difficult to make this particular diagnosis. Sometimes it could be very subtle. There could be a small 1 or 2 red dots, and patient with an accelerated hypertension may come to you with his, so I'm feeling little sick, doctor, I'm not able to understand why I'm so sick. The 2 dots patient might have not seen. If you are too busy, few dots of rashes might be missed by us during the examination. We may consider 50-year-old man, probably it could be an accelerated hypertension, because 2 or 3 visits you are saying every time his blood pressure is accelerating. What was 120/80, visit after 4 weeks, it is 140/100. The visit 4 weeks later, it's around 200/110. Whatever antihypertensive you are giving is not all that effective. So if you carefully observe, probably there may be a subtle clue of 1 or 2, 3 red rashes, which we sometimes, if it is in extremity, we may just pass it off saying that it could be a mosquito bite. So in a sense, the clue could be so subtle, but which could be showing some devastating features over the days later. So we need to consider this as one of the possibilities. Another situations like where the patient is presenting like a septicemic feature secondary to vasculitis, multiple gangrene because of vasculitis, rapidly deteriorating conditions there, because it's being a relatively rare conditions, we quite frequently miss to consider this as one of the diagnoses. We always think, and of course the rule book always says that first suspect a common disease rather than uncommon disease. What I really here say is, yes, we are right first to suspect a common disease, but please remember, you may be seeing an uncommon disease. this doubt will be able to make a diagnosis much more earlier rather than a post-mortem diagnosis. When should we suspect? The most commonest is the skin rashes like this when there are plenty are present, ischemic gangrene when it is present, non-healing ulcers, multiple tender nodules extensively spread or very limited one or two. One need to suspect a possibility of vasculitis. Depending on the type of rashes, one can suspect it could be small vessel vasculitis when it is purpuric rashes. When it is a nodule-like rashes, one can suspect it to be possibility a medium vessel vasculitis. Ischemic gangrene can happen to medium vessel to large vessel vasculitis. So based on these features, one can suspect a possibility of vasculitis. Unexplained hypertension and blood pressure is accelerating, not able to explain what could be the possible reason. Renal involvement where creatinine in the follow-up visit or 2-3 visits you find that creatinine is increasing. Severe visceral pain, ultrasound normal are not able to explain, including testicular pain, chest discomforts or abdominal pain either of an anginal variant or any other variants. Lung lesions, especially a asymptomatic lung lesion or symptomatic lung lesions, nasal crusting, other ENT lesions, one should suspect a possibility of vasculitis. Polyneuropathy, either like wrist drop, bilateral foot drop or various combinations of polyneuropathy or mononeuritis multiplex. Strokes not able to be explained in young patients. Vision loss, altered visual disturbances, one need to suspect a possibility of vasculitis. Headaches, when they are present, one need to suspect a possibility of giant cell arteritis or so, especially in the elderly patients. Half side headache, tender temporal arteries, any such possibilities, one need to seriously suspect a possibility of vasculitis. In a severe emergencies, when you have a sepsis-like symptoms, not able to be explained by any foci of infections, or C-reactive proteins are not very high, or you are not able to explain the source from where the sepsis has come from, one need to suspect a possibility of vasculitis. Unusual another thing which can mimic is an APLS syndrome, one need to suspect when it is a sepsis-like syndrome not able to be explained by any source of infection. If the patient, if you have by a clinical history, he says, I never had a fever, and patient suddenly over a period of time he deteriorates, or had a fever which is not localizable to any source of entry or a port of entry of an infection development of a sepsis, one need to consider, am I by chance looking at sepsis? Sepsis-like presentation of vasculitis. Multi-organ involvement. In the very beginning, you have a renal involvement or an involvement of the lungs, or patient is terribly sick with more than 2-3 organs involved, possibility of a vasculitis should be suspected. Claudication pains, distant claudication or any claudication in either of the limbs, upper or lower limbs or single limb, one need to suspect a possibility of vasculitis, especially claudication suggests a large vessel vasculitis. So the clues are very subtle. Clues can be mimicked by various other conditions which the treatment of which could be in the other direction. It could be an infective endocarditis. Adding steroid would be literally you are pulling the patient in the other directions. It could be sepsis, it could be streptococcal infection which can just mimic a vasculitis. It could be disseminated intravascular coagulation triggered by an infection or a sepsis. Atrial myxomas, relatively rare, but one need to keep a possibility. Amyloidosis can be presenting like a benign purpuric rashes. Cholesterol emboli, drug abuse and others are the possibilities which could mimic like a vasculitis. So you need to exclude a mimicker as well as other possibilities and still keep in mind a possible suspicion that it could be vasculitis. When you think of a vasculitis, the first step is to confirm whether am I dealing with vasculitis or not. I think that will be the topic where the next speaker is going to speak how exactly one can consider a possibility both by investigation. The clinical details I have given, based on clinical details, you can suspect a vasculitis. If it is too straightforward, one can straight away consider clinically that yes, it's vasculitis, but sometimes it's difficult when the clinical features are minimal to confirm 100% clinically that yes, it is vasculitis. So we need to make ourselves sure that the patients is having vasculitis or a mimicker of vasculitis, or is it something else? Once you confirm the vasculitis, the most critical step in the management of this vasculitis is you need to do at the very basic beginning is it a dangerous vasculitis or a non-dangerous vasculitis? In a sense, what we call it as, is it a life or a limb-threatening vasculitis or a non-limb-threatening vasculitis? If you have heard the previous speaker, Dr. Sapan Pandey was telling clear, when it comes to henoxalin purpura or hypersensitive vasculitis, what you need is a reassurance. Assure the patient it's a benign disease, it just gives an ugly look, nothing much more can happen, but still that's not what it is sometimes. Even in henoxalin purpura, 3 to 5% can develop a renal involvement. You need to keep a track. What we thought benign may be moving towards dangerous. The diseases like Wegener's granulomatosis, polyarteritis nodosa or any such are usually life-risking disease. They may threaten the renal, may threaten acute mononeuritis or any such organ-threatening process to happen. So you need to differentiate ourselves that the vasculitis what we are going to deal, is it going to be dangerous to the patient in the long term or non-dangerous to the patient in the long term. The investigations, typing and characterizing vasculitis will help us to take a decision or a call on this particular issue. So once you consider it, investigate to make a reasonable decision about these issues, and once it is clear, one can treat depending upon the extent of the problem. That is, if it's a dangerous vasculitis, go aggressively, try to tackle it as fast, as quick as possible. If it is a non-dangerous vasculitis, as I have said about henoxalin purpura or hypersensitive vasculitis, follow the patient. Follow the patient carefully with each visit at least once in 6 weeks, first 3 months, with a urine routine examination and a creatinine to be tracked. If they are normal, less likely he is going to move into those kind of renal involvement. You can just allow him to say that if it is rashes reappear, come back, otherwise no further management is required. So treatment decision just depends once it is made clear. This particular art, is actually downloaded from the net, which says that actually this is a picture depicting sepsis. I have not still understood why the painter, who is a physician by himself, has made a combination of this picture to call it as sepsis. In a sense, why I took this picture is, if you look carefully, I think he has put a snake which is sneaking through a champagne bottle, and you could see the support system that is required. Probably it's just trying to explain the way the sepsis sneaks in and can cause a devastating problem over a period of time. So what I put and conclude here is that most critical to diagnose vasculitis is to suspect the possibility of the diagnosis. Once you see the patient, think, could it be vasculitis? Probably that's the catch point for us to make a diagnosis of vasculitis. And few points here is that it's not always necessary that you should be able to categorize the vasculitis. Don't wait for the vasculitis to be categorized. Sometimes you may not be able to call it as either as a polyangiitis or Wegener's or whatever the vasculitis sometime. So more important at that point in time to become is to classify primary vasculitis and go on in treating depending on whether it is a dangerous, organ threatening or a non-organ threatening vasculitis. Quite frequently it is said that in one of the publication from the best centers like Mayo Clinic as well as from the other hospitals, it's clearly said that in the early diagnosis of vasculitis, more than 40 to 50% of the vasculitis couldn't be classified into any groups. Over a period of time, in the follow-up, looking at the way the disease process evolved, they could categorize another 20% in, still 20% remained as an unclassifiable vasculitis. For patient's sake, maybe for an academician, when we try to publish, the question may be raised, why did you have such a large amount as an unclassified vasculitis? But it doesn't matter. But if you still keep it as unclassified vasculitis and treat them aggressively if it's an organ threatening, remaining unclassified doesn't really disturb the patient, because that's what you have achieved, because you have achieved the progress of the disease to develop into a full-blown disease. Thank you very much for patience here.
Thank you, Dr. Chandrashekara.